All right, so we have some time for Q&A, and I want to show you a little video, but let's talk about this. Kleiman, get ready. How long do you keep patients on dual antiplatelets post-TAVR?
Keep it short. First of all, there is absolutely no evidence that patients with TAVR benefit at all from having a second antiplatelet drug. We've sort of adopted that from the coronary stent situation, maybe completely wrong. So the answer is generally 1 month, 40% have atrial fibrillation. They get an oral anticoagulant and clopidogrel only, no aspirin. And if they've got any bleeding, we stop the stuff.
Is TAVR for patients less than 50 years of age a possibility, and the other one, a possibility of redo TAVR?
Okay, so first of all, redo TAVR, very easy to do, much easier than de novo TAVR, so the answer is yes. Putting a valve inside another valve is generally very easy. Patients less than 50, I didn't get to talk about this at the end. These are generally low-risk patients. So first of all, many of them will have congenitally bicuspid valves. You've got to be aware of them. Bicuspid valves are different in size and shape. They're frequently oval. We're trying to put a round valve in them. So device success is a little bit lower, although if you look at outcome, because they're young, they generally do fairly well, but you should be careful. The valves are also much more heavily calcified than senescent aortic stenosis. They don't have nodules of calcium, they've got through and through calcium. That makes it tougher to expand the valve and you can cause some damage. So beware, patients young and has aortic stenosis, they may well have a congenital bicuspid valve. If you are in East Asia, they almost certainly have a bicuspid aortic valve. That is a genetic difference that's being worked out now. Finally, CMS has said that they will pay for TAVR according to FDA indications. So if a patient is in the low-risk group, the only circumstances under which CMS will cover it is if they're enrolled in an approved clinical trial. So there are only 2 trials in the US that are approved and for which CMS will cover the cost of TAVR. And TAVR is not cheap, as Dr. Ramchandani told you. TAVR valve costs $32,000, which is more than I've ever paid for a car, including my Porsche. Keep that in mind.
His Porsche is 1985, so.
A lot less than $32,000.
It has increased in price lately. A question for you, Mahesh. Do you do minimal surgery for AVR in all patients, or still some require traditional surgery?
I use the minimally invasive approach for all patients who need an isolated aortic valve replacement, with rare exceptions. If they've had a previous sternotomy and it's a redo chest, and they're morbidly obese, then I wouldn't do it. If they've just had a redo sternotomy and they have a normal body habitus, then yes. Patients with very severe COPD who cannot tolerate single lung ventilation, which is a very, very small group of patients actually, are also patients I might hesitate because for a short period of the operation, they need to be on single lung ventilation. But I would say that in my practice now, greater than 90%, probably close to 95% of patients who need isolated aortic valve replacement, that is, they don't need to have a coronary bypass operation or a mitral valve procedure or anything else, will have a sternum-sparing approach, yes.
Yui, you have 2 questions here. See if you can.
I'm glad. I was feeling lonely. I thought maybe nobody wanted to
It looks
ask
like
me questions.
You're generating some questions.
Good. Okay. So what congenital heart disease requires anticoagulant? So the problem is there's a lot of sort of class 2A, 2B sort of thing, but class 1 is easy stuff. Atrial arrhythmias, so atrial fibrillation, atrial flutter is very common in our patients because of scar lines after their surgical repairs. So that's one indication for anticoagulation. Another one is oftentimes they actually get a mechanical valve. So for example, they may get a mechanical much valve. That's also another major indication. So the traditional ones are pretty clear. Some of the more gray areas that we're beginning to find, also Fontan. So a lot of Fontan patients, because they're protein-losing enteropathy, they have protein C and protein S type of deficiencies, and then they can become procoagulable, and so therefore you need to actually anticoagulate some of those. But that's a little bit more of a gray area. Some of the other gray areas are patients who actually have permanent pacemakers who actually still have persistent right-to-left shunting at the atrial level. That is a little bit scary because we have all seen cryptogenic strokes in those patients. And so that's another area that we're thinking about, but has no real definitive solution. Other thoughts that are sort of in the field now are NOACs appropriate for these patients. And I typically use them because I think that they're right in atrial arrhythmias. Other types of indications, not so sure. Why is there an increase? Well, it's basically history. So my job is basically understanding medical history. So the history of medicine and history of cardiovascular surgery, because basically everything I do is to sort of stay 20 years behind the surgeon. So what the surgeons were doing 20 years ago is what I'm dealing with now. So if you can imagine, it takes about 15, 20 years for something that's innovative to trickle out into the rest of society. So for example, if 1953 was the first time you could actually do cardiopulmonary bypass and repair an atrial septal defect, it wasn't until the sort of the 1970s when everybody was repairing atrial septal defects. So if there was a pioneering surgery for single ventricle in the early 1980s, it wasn't really until basically 10, 15 years after that that everybody started doing palliation for single ventricles. And so now you can see how everybody's beginning to catch up, and now there's about a 90-something% survival for a child who's born today with any type of congenital heart disease to adulthood. So that's why we're seeing so many more nowadays. And in addition, the other point is that, yes, it's absolutely possible that some of these patients are being identified through good prenatal care. So if you do the right kind of prenatal care, the initial 20-week, 24-week anatomical screening will identify a lot of these really critical congenital heart lesions like transposition early on, and then we can actually get these babies good care, and then they'll survive. Also, obviously, advocacy and education. So Jimmy Kimmel coming out and talking about tetralogy flow. Now everybody knows about tetralogy flow, and now people know to actually look for it. So when their baby turns blue going home, they know immediately bring the kid back because there's a problem.
Last question is for you, Huey. Do all VSD patients need an intervention, especially when they are asymptomatic?
Yeah, that's a challenge. So the typical problem that I often see is that we'll have a VSD that was followed throughout childhood, turned into absolutely nothing, got small, and there's no issue. But then one of my nightmare scenarios is that it actually sits right underneath the aortic valve, and it gets ignored, and then the patient starts to have aortic valve prolapse, and then ultimately severe aortic regurgitation because it hasn't been followed. So the answer is no if they're asymptomatic and it's a restrictive VSD, but that doesn't mean that they don't need follow-up. So for most of these patients, I typically see them once a year, and I get an echocardiogram once a year, once every couple of years, just to make sure that nothing has happened.
All right, well, we're getting close to our lunch break. When you're gonna get out from here, or when you came in, you saw a huge building under construction. I know people at Methodist here know that this is our future home for Heart and Vascular Center. It's an addition to our home. Actually, we're very excited about it. So before I let you go, I wanted to share with you a video of what our new home next year, 2018, will be like. So can we roll this video? And we're very excited about it. So hopefully you'll get as excited. This is where you are on the left side here, where we are in this building, and this is the new building. These are how the new patient's room will look like. Hopefully you don't have to be there.